Okay, I'm delighted to be joined today by Bill Strohl. He's the former Biologics discovery leader at Merck and J&J, and is currently president and owner of BiStro Biotech Consulting. I'm delighted to be working with Bill on this year's PEGS Boston. He's going to be speaking around the super hot topic of immunotherapies for autoimmune diseases. Bill, thanks for joining us today and talking about this really excellent.
My pleasure.
So, Bill, for many years, the antibody and, to an extent, cell therapy industry has focused so much its attention on the oncology space. We're kind of seeing not a flip, but kind of an extension into immunotherapies for autoimmune. I wondered if you could kind of give us a sense of why there's so much excitement, both in the scientific and the investor community, around immunotherapies for autoimmune disease.
Yeah, so a lot of companies, of course, have invested for years, even decades, in the oncology space, and what that has resulted in, and one of the things that it's resulted in, of course, is that it's a very saturated space. So in almost every disease and on almost every target, there's so many different candidates, and so it's become extremely competitive. And so investors and companies alike have been looking to expand the role of biologics in other types of diseases. And about 5 years ago or so, a couple of different scientists, but in particular, George Schett out of Germany in his laboratory investigated the use of CD19 CAR-T to treat lupus patients, patients with SLE, very severe SLE. And the goal here was to deplete the pathogenic B cells. And they did so. And the lupus patients actually got better. And so that was sort of the light, I think, that went off in everybody's head that said, wow, if you can do this with a CAR-T, maybe you can do it with other types of CAR-Ts, maybe allogeneic CAR-Ts instead of an autologous like that one was, or bispecific antibodies, which are T-cell redirecting, which in effect work a little bit like a CAR-T, but they're antibodies. And so this field has just really started to come open, and there are just a few players really who are in the game right now. There are people dabbling, and the toes are in the water, but there's some very interesting possibilities, I'll call it, that are starting to come out. And I can explain a few. For example, in the CAR-T space, there are actually 69 different unique CAR-Ts that are being used in autoimmune diseases. These are CD19 CAR-Ts, BCMA CAR-Ts, CD19 BCMA CAR-Ts, CD20 CAR-Ts, those kinds of CAR-Ts. But interestingly, most of these are in China. So out of the 69, 52 are Chinese-based and 17 are in the West. So China is actually leading really in a lot of ways in this new field. As frankly, recently they've become leaders in biologics, even more in a more broad sense. In terms of the bispecific antibodies, there are only a handful of bispecific antibodies that are T-cell redirecting bispecific antibodies that have been approved. It's about 7, I think. And a couple of these are CD20 by CD3 CAR-Ts. Bispecific antibodies. The original one, Blincyto, of course, is CD19 by CD3. And now it's expanded. There's a couple of BCMAs, and one GPRC5D. So these are B cell depleting antibodies, and they are being at least investigated, I'll use that term, right now, especially the BCMA and the CD19s are being investigated to see how they might work in this new field. If you want to call it a new field, it's just an extension really of an older field. But the concept of depleting antibody producing B cells, plasma cells, for example, or the cells that are developmentally before that can become later on antibody producing cells. And the key here is, and this whole area, the whole key here is to reset the B cell repertoire. So you have pathogenic B cells producing pathogenic antibodies, autoantibodies, to self proteins, and then those B cells need to be depleted, and so you go in and you do a very deep depletion if you can, and that's why CAR Ts and T cell redirecting bispecific antibodies are good, because they are very good depleters, and they can give you this deep depletion. And then you get the reset, and your reset is going to be hopefully naive B cells, right? And so then after some period of time, you may get pathogenic B cells coming back. You might have to retreat, but conceptually, that's the idea, is to reset the B cell repertoire.
Okay, so the opportunity here seems to have come. We have a lot of content early years on oncology. The autoimmune space, is this seen to be a more work going on in autoimmune with regard to less work going on in cancer? I know we mentioned kind of there's a crowded space in that area as well.
I don't think the work in cancer has let up too much. It's still very, very crowded space, and will continue to be. But now what you're saying is, so these are treatments that are very, very strong treatments. And they are. They bring with them some side effects that, 10 years ago in the immune space, those side effects may not have been acceptable. And yet, now as we look at more severe diseases and being able to manage some of these side effects, like cytokine release syndrome, for example, right? As we can start to manage some of these side effects, then some of these more difficult or tougher types of therapeutic approaches can be used.
Okay.
And that's what's happening. People are starting to see this and see how to use them.
So would you say we're at the very, very early stages of this new field?
I would say we are still in the opening of the door, right? We're looking into this. There are very few, actually, as it stands right now, there's no single antibody or CAR T that is approved by the US FDA for autoimmune diseases. When I say that, I mean T cell redirecting, bispecific antibody or CAR T. There's several in clinical trials. Like I said, in CAR Ts, it's about 69. In the case of bispecific antibodies, T cell redirecting bispecific antibodies, maybe about 10-ish. It's not that many that are in clinical trials. So I think we're going to see this explode over the next few years. We at IGM actually had a few that were in clinical trials. We had some difficulties, and so they're not continuing forward. But you will start to see more of these come out.
Okay. What do you think would be the winners in this class? So in terms of, are we looking for enhanced safety? Is that one of the key considerations versus oncology? What are
that's
the
tough.
key indicators?
Yeah, predicting winners. So in the CAR T space, I like the allogeneic CAR Ts. And the reason I like that is because they're off the shelf and they don't have to go through this 3-week processing period, to get the actual therapeutic as you would with an autologous CAR T. In the bispecific T cell redirecting space, it's going to be the ones that offer both deep B cell depletion, especially in the tissues and bone marrow, and at the same time do not promote ICANS and neurological problems and cytokine release syndrome, or at least have the cytokine release syndrome in a manageable level.
Okay. Well, Bill, I know you're going to be talking about this in your presentation on the Advanced Immunotherapies track at Pres.t Boston, giving us a nice overview. We've also launched a track dedicated to biologics or immunology indications as well. So this is becoming a key theme across all the industry developments, but also particularly at Pres.t Boston. So very excited to see your talk. We very much look forward to seeing you this May.
Well, thank you. I'm very excited to give this talk. I think this, it's going to be an area that will be very hot over the next several years.
Excellent. Well, we have lots of this content. We have some autoimmune indication focused on the cell therapy meeting and also on our general immunotherapy track. So please head to the website for more information. We have registrations coming in the next few months, so please make your way to the website where you can meet Bill and myself and the rest of the team all focusing on this topic. So thanks very much, everyone.